Good morning. My name is Dr. Mary Stephen. Welcome to the WHO Africa Media Briefing, which is taking place in collaboration with the APO Group. First, some housekeeping. We have interpretation in both English and French. Go to the bottom right-hand corner of your screen, click on the globe icon, and select your most preferred language. And today, joining us from Brazzaville, Congo, is Dr. Benido Impuma, the Director of the Universal Health Coverage Communicable and Non-Communicable Diseases Cluster. And I will let Dr. Benido to introduce our remaining panelists.
And thank you, Mary. Good morning and good afternoon to all the journalists joining this press conference ahead of the World Diabetes Day. I would like to express my sincere thanks to all of you for the great support you've been giving to the WHO Regional Office for Africa in conveying the right information on COVID-19 in our region. Today, we will look at how COVID-19 is impacting people living with diabetes. As you know, all our 47 countries are experiencing COVID-19 as we speak right now. But we also have in our region millions of people who are living with diabetes. So we need right now to fight not only COVID-19 pandemic, but also the global epidemic of diabetes. I'm pleased to be joined for this conversation by Professor Maïmouna Mbaye, who is the director of the National Diabetes Center in Senegal. Professor Mbaye will discuss how Senegal is coping with diabetes and COVID-19. Mr. Greg, the CEO of Diabetes Africa, will also join us to explain what needs to be done to support people living with diabetes, what actions, countries, but also partners, as well as people living with diabetes can take to alleviate the burden of diabetes in our region. Welcome and thank you both for being here. There have been more than 8.5 million COVID-19 cases in Africa, and more than 200,000 lives have been lost. The sustained decrease in new cases continue in almost all sub-regions of the continent. This is quite good news. But after dropping for 10 weeks in Southern Africa, new cases have jumped by more than 60%. This is mostly due to a spike in Botswana, and we are closely working with the Ministry of Health to explore or to understand why are we seeing this spike in Botswana. In addition, the Republic of the Congo, Mauritius, and Egypt are trending upwards or on a high plateau in recent weeks. With these flare-ups, there is no time to sit back and relax. We must do everything possible to prevent COVID-19 from gaining the upper hand. With just 6% of the continent's population fully vaccinated, COVID-19 still poses a very real threat to population in Africa. This is especially true for people with diabetes. A preliminary analysis shows that death rates from COVID-19 are significantly higher in patients who also have diabetes. The survey of 13 countries conducted in our region found a more than 10% case fatality rate for people with diabetes, compared to 2.5 for COVID-19 patients overall. This shows that fighting the diabetes epidemic in Africa is in many ways as critical as the battle against the current COVID-19 pandemic. COVID will eventually subside, but Africa is projected in the coming years to experience the highest increase in diabetes globally. We must act now to prevent new cases. All Africans at risk of diabetes must have access to testing. In fact, in Africa, about 70% of people with diabetes are unaware that they have the chronic condition. Health officials in Africa should take advantage of the increased availability of low-cost rapid diagnosis tests to routinely test patients in diabetes centers to ensure early detection and proper care. These centers can also be key venues for vaccination. When it comes to vaccination globally, people with diabetes and other underlying conditions have been prioritized, but Africa has faced challenges with this strategy. Data from nearly 40 countries find that nearly 14% of all COVID-19 vaccine doses administered so far have gone to Africans with underlying conditions. While there is some progress, 9 months since COVID-19 vaccination campaigns began in this region, we are nowhere near where we need to be with protecting our most vulnerable populations. There's an urgent need to step up vaccination and other key services to people at high risk, including those with diabetes. During the COVID-19 pandemic, access to diabetes care has been severely disrupted in the African region. Lockdowns to limit the spread of COVID-19, for instance, have impeded access to healthcare and the basic elements of proper disease management, such as routine glucose monitoring and eating a healthy diet. To improve equitable access to quality diabetes care, WHO launched what we call the Global Diabetes Compact in April 2021. This builds on work in recent years to roll out the WHO package of essential non-communicable diseases intervention from primary health care in low-resource settings. So far, 21 African countries have started using this package. Benin, Eritrea, Eswatini, Lesotho, and Togo have achieved national expansion covering all primary healthcare facilities. In closing, I would like to offer my sincere condolences to the people who lost their loved ones in the explosion that took place in Sierra Leone last Friday. As WHO, we've been closely working with the government to provide care for the survivors and have delivered enough medical supplies to treat hundreds of burn victims. With that, I thank you. Mary, back to you.
Thank you very much, Dr. Impuma. So, and now to you, Professor Maimouna Mbaye, as a doctor on the front lines of the diabetes response in Senegal, can you tell us how the disease is surging and the challenges you're facing, and also in the context of the COVID-19 response? What are the challenges you're experiencing with people living with diabetes in Senegal, and if there are some achievements and innovations that you have used during this COVID-19? Thank you. Over.
Merci beaucoup. Merci pour cette invitation. C'est un grand plaisir pour moi de me joindre à vous et aussi à tous les journalistes invités à la conférence de presse de ce jour. Au Sénégal, comme partout ailleurs dans le monde, le diabète ne cesse de progresser. Comme dans la majorité des pays africains, il n'existe pas de collecte de données de routine. Toutefois, la première enquête nationale conduite en 2015, selon l'approche stepwise de l'OMS, a révélé que 3,4% de la population âgée de 18 à 69 ans était diabétique et que cette prévalence passait à 7,9% chez les plus de 45 ans. Les statistiques hospitalières, notamment celles du Centre national de lutte contre le diabète, le Centre Marc-Saint-Calais, confirme cette progression. Dans les années 1980, on enregistrait en moyenne 200 nouveaux cas par an et en 2005, le recrutement annuel est passé à près de 2500 nouveaux cas, soit une augmentation de près de 10 fois, et ceci en l'absence de dépistage systématique. Actuellement, notre service suit près de 60 000 diabétiques qui proviennent de toutes les régions du Sénégal et même des pays de la sous-région. Entre 2018 et 2019, le nombre de consultations a augmenté de plus de 20%. En 2020, nous avons constaté une baisse importante du nombre de consultations, mais ceci était probablement lié à la pandémie à COVID-19. C'est dire qu'avec cette progression galopante, le centre Marc Santalé a très largement dépassé sa capacité d'accueil et ceci retentit sur la qualité de la prise en charge des patients qui ne bénéficient plus que d'une voire ou 2 consultations par an au lieu d'une consultation tous les 3 mois tel que c'est recommandé. À l'échelle nationale, malgré les efforts consentis pour décentraliser les soins et former les professionnels de santé, les ressources humaines restent encore insuffisantes, de même que les infrastructures, y compris les laboratoires nécessaires à la prise en charge correcte de la maladie. Par ailleurs, notre pays, comme la plupart des pays africains, ne dispose pas encore d'un programme national de lutte contre le diabète. Certes, il existe une division de lutte contre les maladies non transmissibles au sein de la direction de la lutte contre la maladie au ministère de la Santé. Des normes et protocoles ont été élaborés pour améliorer la prise en charge et de nombreuses activités sont menées, mais toujours dans le cadre de projets financés par des bailleurs extérieurs, avec toujours le défi récurrent de la pérennisation, parce qu'il n'y a pas de financement étatique. La pandémie à COVID-19 est venue assombrir ce tableau. Les statistiques montrent que le diabète et l'hypertension artérielle sont les comorbidités les plus fréquemment associées au décès chez les patients hospitalisés pour COVID et l'impact émotionnel et psychosocial est très important chez nos patients. Et de nombreuses perturbations ont été observées dans les services de maladies non transmissibles et de diabétologie en particulier. Par exemple, dans notre service, la moitié des lits d'hospitalisation ont été alloués aux cas COVID. Il ne nous reste plus que 20 lits pour les cas non COVID. Une bonne partie du personnel a été affectée au centre de traitement des épidémies. Des activités jugées non urgentes telles que le dépistage systématique des complications chroniques du diabète ont été reportées. Les rendez-vous de contrôle ont été différés pour les mêmes raisons, mais aussi par phobie des structures sanitaires, diminution des transports publics et d'autres problèmes. Et pour faire face à tous ces défis, des innovations ont été mises en place. Et cela même avant la pandémie à COVID-19. Le Sénégal est le premier pays d'Afrique francophone à appliquer le programme mondial Be Healthy, Be Mobile pour améliorer la prise en charge du diabète. Il s'agit du projet M-Diabète qui consiste à utiliser le téléphone mobile pour véhiculer de simples messages de prévention du diabète à la population. Et en 2014, la plateforme M-Diabète avait servi à envoyer des millions de messages de prévention contre l'épidémie d'Ebola et elle a aussi servi contre la présente épidémie à Covid. Et d'autres projets de télésanté sont en cours. Consultation à distance pour certains patients depuis le début de la pandémie, télédépistage de la rétinopathie diabétique, e-learning pour les professionnels de santé. Nous sommes quand même conscients qu'il reste encore beaucoup à faire et je serai heureuse de répondre aux questions des journalistes. Merci beaucoup.
Thank you very much, Professor Mbaye. Yes, we definitely need to double up on our fight against diabetes in Africa. And of course, the COVID pandemic has impacted the services for diabetic patients. And to you now, Mr. Gray, can you please tell us about the challenges a person living with diabetes is facing? What innovations are needed to fight against this disease, and how can diabetes be managed in low resource settings?
Thank you very much, Dr. Mary, and thank you, Dr. Benito and Professor Maimuna for these remarks, and thanks WHO for this invitation, and thank you all the journalists for being here today. Before I answer your question, I just wanted to say a few words about Diabetes Africa. She's a network of some 1,500 members and subscribers, volunteers, healthcare professionals, entrepreneurs, business professionals, and people living with diabetes, as well as community leaders who are committed to making a difference for diabetes in Africa and in people of African origin. During the pandemic, we've been keeping our ears to the ground, and what we have heard coming back from our network is that this has been a very challenging period for people living with diabetes and for healthcare professionals. It's clear that the pandemic has had a very negative impact on our community. And our message today is that we can make the biggest impact on COVID by starting with non-communicable diseases and diabetes, looking at non-communicable diseases and focusing our efforts on these conditions can help us be a lot more efficient when fighting viruses such as COVID. And that's really something that has come clearly out of the pandemic. You have asked me to talk a little bit about the challenges of people living with diabetes in general, but also during the pandemic. And here is what I would say. The number one challenge for a person living with type 1 or type 2 diabetes in Africa is diagnosis. People living with diabetes may not know they have the condition until serious complications develop. That's because looking healthy is not the same as being healthy. And people with excess blood sugar, particularly in the case of type 2 diabetes, can live without experiencing complications for a long time. And that's a message that we need to amplify and communicate more widely. As Professor Benito said earlier, it's quite possible that up to 70% of people living with diabetes are not aware that they have the condition. But when the complications of diabetes do manifest, they present huge problems for livelihoods, but also for health systems that are already strained. We're not talking about light complications. Professor Maimouna mentioned it. We're talking about blindness, amputations, heart emergencies. These are very costly and life-changing complications for people who are experiencing them. And in many places across the continent, the challenge is compounding by the lack of testing facilities or training among health workers that would enable them to identify risks early on. The earlier type 2 diabetes or pre-diabetes can be diagnosed and treated, the better it is for the person and for the community at large. Among the other challenges that people are living through on a daily basis is the cost and access to medication. You need to bear in mind that managing blood glucose levels or blood sugar levels requires testing regularly, and this presents challenges on its own. People living with diabetes should receive adequate training on the topic, but also be able to afford it. How can we expect people to test regularly and to control their diabetes if they must choose between feeding their families and buying test strips? In many cases, these are the type of heart-wrenching decisions that are being made by people living with diabetes. Now, during the pandemic, this situation has been made even more difficult, and for two reasons. The first one is that COVID-19 has increased the risk for people living with diabetes. We have mentioned it. People living with diabetes are more likely to have more severe symptoms of COVID-19. Research is still ongoing, but we have anecdotal evidence coming from our network from Africa that tends to corroborate the research done in the UK and in the USA in particular. In the Democratic Republic of Congo, for example, the analysis of a small sample of 215 people who died of COVID-19 showed that 30% of them had diabetes. So this is one aspect of the pandemic, but the other aspect that has made the situation much more difficult for people living with diabetes has been, initially at least, the public response to the pandemic. The initial reaction to the pandemic has been to encourage people to stay at home and reduce visits to the hospital. People living with diabetes have also chose to stay at home for fear of catching the virus. But with the pandemic stretching into 2021, this did not prove to be a sustainable solution. Of course, it's possible that the focus on health in general has encouraged some people to control their diabetes better and make an extra effort. But in general, COVID-19 and its associated restrictions has meant that people became more sedentary. They stayed at home. They experienced stress and anxiety, particularly with regard to the economic situation, and had more difficulties keeping a healthy diet and controlling their diabetes. So luckily, in most instances, hospitals and healthcare providers have acknowledged these challenges and made a special effort to allow people living with chronic conditions to receive face-to-face care. And telemedicine, which Professor Maimouna mentioned, has helped. But in countries where phone calls and video calls were a workable option, for example, in Nigeria or in Kenya, but in other countries, such as Uganda, for example, the cost and technical challenges of telemedicine were often prohibitive. I want to acknowledge the role of civil society organizations that have helped keep the focus on tackling diabetes during the pandemic. In Kenya, the Non-Communicable Disease Alliance has been actively advocating for essential diabetes medicines to be covered by the National Health Insurance Fund. We need more of this type of advocacy role by civil society organizations. I also want to acknowledge the community groups of people living with diabetes. Despite the pandemic, these are lifelines for people living with diabetes. And despite the pandemic, these groups have continued to connect and help each other. And this has been very important for people living with diabetes. When it comes to innovation, what can we do? I just want to frame the conversation about diabetes and diabetes care and what we should be doing. We can't look at diabetes in isolation and ask what we can do with less resources. Adequate healthcare demands a basic level of resources, and given the impact of non-communicable diseases on the overall system, we have to say that diabetes remains largely underfunded. And that's regrettable because managing health in a low resource settings where there are difficulties funding healthcare, managing health in this type of setting would benefit from actions that reduce costly complications such as early diagnosis and prevention of diabetes. People who stay in the hospital with COVID-19 often have associated conditions, what we call comorbidities, and diabetes is one of these comorbidities. If we can address these comorbidities at the source, we can reduce the number of people who are suffering from complications later down the line or suffering from complications of COVID-19. And I would say, in line with what Professor Maimouna has said, that one of the greatest innovations in a low resource setting would be to change mindsets, to consider investing in keeping people healthy rather than fixing problems. There will always be emergencies and costly operations that cannot be avoided, but diabetes doesn't need to be the cause of these costly operations. So we have to train healthcare professionals, inform policymakers, and so that keeping people healthy with exercises, nutrition becomes a priority. We need to share knowledge at a much greater scale, which is what Diabetes Africa aims to do. And we also need to think outside the box, working with commercial organizations, in particular in the food and beverage industry, to label products, help people make more informed decisions. Not everything will be solved by technology. There is a lot that can be done with sound policies and with commitment at the top level of decision making. Thank you very much for the opportunity.
Okay, thank you very much, Mr. Greg. Yes, prevention is always better. So now that you have heard from all our panelists, our dear journalists, it is your time to ask your question. And to do this, please use the Q&A function on the Zoom platform. Tell us your name, the name of the media organization you represent. And if you want to go live, please indicate in the Q&A. We have on hand additional colleagues from the WHO Regional Office for Africa, Dr. Fiona Atuhibe, the new vaccine introduction officer, Dr. Tiano Balde, the COVID-19 incident manager, Dr. Jean-Marie Dango, the regional advisor for non-communicable diseases. And also from Diabetes Africa, we have Dr. Eva Njenga. All are here to answer your questions. So please, we are going to start with the questions. Daniel, are you ready to ask your question, please?
Yes, I'm ready. Can you hear me?
Yes, please go ahead.
Well, thank you very much. Mine goes to either Dr. Craig or to the WHO, Dr. Benito. Now, we have witnessed a number of African countries relaxing COVID-19 protocols. How do we reconcile this with the death toll? And are we on the right path, really?
Okay, so I'll pass your question to Dr. Benito, and Dr. Tiano Baldo can complement.
Thank you.
Thank you very much. I think we are closely working with national authorities to ensure that all public health measures that are required are still maintained, because like you are seeing, the COVID-19 is not yet over. Although we are seeing a downward trend, it's not yet over. So it's extremely important that we continue to maintain many of the public health measures that have been proven to be effective, to ensure that we do not experience subsequent waves. So that's like our key message as far as the response to this pandemic is concerned. In addition to that, one of the things that we are really suggesting is not just to focus on the response to COVID-19, but also look at other health issues that are prevalent in this country. So diabetes is one of them, but we also have like non-communicable diseases, HIV. So it's important, while we are responding to the ongoing COVID-19, we ensure that we are also addressing some of these silent killers.
Thank you, Dr. Benito. Dr. Balde, do you want to weigh in here?
Yeah, thank you so much, Mary, for the question. And we have seen definitely this declining trend currently of COVID-19 cases and death in Africa. However, we really have to say, as Dr. Benito said, the outbreak is quite still active here. And we have seen, this increasing number of cases in Europe, and we know the connection between Europe and Africa. So, and at the edge of this festive season, we know that cases will also, increase, because we know that people will still gather together. So it's really, really important to keep in mind that, the application of all of these public health and social measures that we've been promoting. And we are really supporting member state countries, for trying to get ready for this festive season. And just in addition to this one, also to mention, like currently the focus of the outbreak where we are really seeing a kind of active cases is really in the Central African region here, including countries like Cameroon, Gabon, and also the Republic of Congo here. Otherwise, the pandemic is still active, cases are being detected, and we really need to take all of the different measures for really addressing those issues. Thank you, Mary, and back to you.
Thank you, Dr. Balde. And this next question is coming to you, Professor Mbaye. The question is coming from KBC in Kenya. Have African governments and states done enough in sensitizing the public about the relationship between COVID-19 and diabetes? Even so, do you think with diabetes have been given priority in the administration of COVID vaccine? Do you think people with diabetes have been given priority in administration of people with COVID-19 vaccine? You start first and Dr. Dango will complement.
Oui, la priorité, merci beaucoup pour la question. La priorité a effectivement été donnée aux personnes diabétiques pour l'accès au vaccin. Et nous avons fait beaucoup de communication à ce propos-là, particulièrement dans les centres de prise en charge justement des diabétiques, pour que les professionnels de santé qui sont plus proches de ces patients arrivent à les convaincre à se faire vacciner. Et ça, c'est la même politique qui a été adoptée pour toutes les autres pathologies chroniques telles que l'hypertension artérielle, l'insuffisance rénale et aussi chez les sujets âgés. Donc, nous avons très tôt beaucoup communiqué à ce propos-là pour les mettre en garde sur les risques qu'ils encourent avec la COVID-19 et les rassurer, parce que beaucoup de personnes avaient peur de se faire vacciner, les rassurer sur l'innocuité de la vaccination et sur les bénéfices justement en termes de prévention des complications liées à la COVID-19.
Thank you, Prof. Dr. Dango, do you want to weigh in the prioritization of people with diabetes concerning COVID vaccine and desensitization about diabetes?
Thank you very much, Mary. Yeah, for sure, diabetes prevention is something very important, and it relies on healthy lifestyles. So for people with diabetes, or for what has been called healthy people by Greg, they should avoid these factors such as overweight, obesity, physical inactivity, harmful use of alcohol, a lot of sweetened beverages, and also they should take care of their mental health by having or avoiding too much stress. These are very, very important measures to be taken by individuals if they want to avoid getting diabetes, or if they already have diabetes, so that the diabetes can remain well controlled. That's very important at individual levels. So in terms of a recommendation for health authorities at country level, looking at what are the main challenges at country level, we are urging national authorities, but also partners, to assist in getting, providing access to diabetes diagnosis by providing enough glucometers, strips at community level, but also at primary healthcare level. So they should democratize the access to diabetes diagnosis, so that this big number of people in our region living with diabetes without knowing their status can know it and take appropriate actions. Over.
Thank you very much, Professor Dango. And to you, Dr. Benito, this question is coming from SABC. Are we still likely to have fourth wave around December or so? How should countries prepare themselves? And when you finish, to complement this question, Fiona, if you can tell us why vaccination is still at 6%. Where are the bottlenecks? So over to you, Dr. Benito.
Thank you very much. I mean, what we're seeing right now, like I was saying, it's a downward trend, but we are still at the middle of the pandemic. We cannot predict when the next wave will occur. But I think what we need to do right now is to take advantage of this period where we are seeing few cases to get prepared to ensure that all actions that are required in terms of surveillance, preparation of healthcare facilities, community sensitization, all the preparedness measures can be implemented so that we are ready. Should there be an upsurge of cases, countries will be able to respond quickly. So I think it's really now time for strengthening our health system, our systems for detection and response to this pandemic. So that's something which is important, because if we start relaxing, should there be a fourth wave, no one knows what can happen. So it's important that we take advantage of this period to ensure that all appropriate readiness measures are put in place. We're also closely working with our partners, including COVAX in Geneva, to ensure that we can scale up vaccination in all countries in this region, so that we can achieve at least the said 70% target of people who are fully vaccinated in Africa. So that is work which is ongoing, and we encourage all countries to really use the available vaccines that they have, so that we achieve the expected immunity in our population.
Thank you. Yeah, thank you, Dr. Benito. And Dr. Tiano, as the incident manager, do you want to weigh in on the fourth wave? Dr. Fiona, I come back to you with the vaccination.
Thank you, Dr. Mary. I think Dr. Benito have said it all. We know that at what we have observed over the past 2 years, it was this really major peak, both in December during the summertime, and after that also in December. That's what we have observed last year. And we know that the factors driving, these upsurge of cases are still around. We know that the low vaccination coverage that we have in our region here, and the circulation of the Delta variants, which is currently also happening in many of our countries. So definitely the risk of having really spike of cases is quite very important. And that's why we wanted to re-emphasize on the point mentioned by Dr. Impuma on the necessity of really taking all of the different actions, by our member state countries and also partners to get really ready, because this will happen. And we are supporting really all of the different countries for doing so. And from the regional perspective here, as I was saying, countries in West Africa, in Central Africa, where we know also that the kind of cold season will happen in around January and February, the risk of having these new cases is quite important. So definitely, and we are requesting our colleague journalists here to pass the message. The outbreak is still on, is still active. We are having a lot of transmission of cases in some of the countries. So really, we really need to refocus again, on these different response action. Thank you, and back to you, Mary.
Thank you, Dr. Balde. Dr. Fiona, so I add one more question to you, in addition to the question on why is the vaccination rate still at 6% and the bottleneck. Also, does WHO have any plan or advice for child vaccination in Africa now that children are said to be getting infected with the COVID-19?
Thank you very much, Mary, and those are really very relevant questions. So why is Africa still at 6%? We know that one of our biggest bottlenecks at the start of the whole vaccination process was the access to vaccine. It has taken Africa such a long time to even get to the 6% compared to a country like UK, for example. It would take them just a week to get to that level. So at the beginning, our biggest issue was vaccine access. The vaccine supply has now rapidly increased, gradually increased over the last few months, and we are seeing more doses coming onto the continent. Now we've moved from a vaccine supply issue to a vaccine utilization problem. And now WHO has gone out of the way to go ahead and get into these countries, have targeted support for countries that have low absorption, like the Democratic Republic of Congo, countries like South Sudan, countries like the Republic of Congo itself, Cameroon, a number of countries that we've put targeted support to help them increase their vaccination. So right now, we no longer have the issue we had of access to vaccine, but it doesn't take one day or overnight to change, to ramp up this vaccination from facilities that had even closed. We had countries that had closed the vaccination campaigns because there was no vaccine. But now that is being solved, and we hope to see better by the end of the year. So when it comes to vaccination among children, we follow science at the end of the day. So we know that for the Pfizer vaccine and the Moderna have the messenger RNA, the Pfizer vaccine actually in particular, has been approved by WHO to vaccinate children up to the age of 12. So in some African countries, and because that is what science has shown, we have not yet seen the science and results that have come from lower age groups, but those studies are ongoing. So we have countries that in Africa that have decided to extend vaccination to age groups to the age of 12. But we have also seen countries that have made a decision, because these decisions at country level, recommendations are made by the National Immunization Technical Advisory Groups. For example, Uganda has made a decision to vaccinate up to the age of 12, but only those 12 to 17 with comorbidities. However, we are still waiting on science, and again, the WHO recommendation remains, before we extend the vaccination to the younger age groups, please let us ensure that we vaccinate the older age groups first, because the disease has shown to be more fatal and more serious in people who are older than children. That is why children are still not a high priority for now. Over.
Thank you very much, Dr. Fiona. And Dr. Balde, are we confident that we could be on our way to flattening the curve now that infections and fatalities in African countries have reduced significantly?
It's difficult to say, but we can mention that the dynamic that we are observed here in the region since the beginning of this pandemic has been quite low in comparison to other regions, and this is due to different and many factors. But what is really important at this point is to continue monitoring, the situation, how the situation is evolving, understanding the dynamic of the pandemic in each of the location, in each of the countries, even within the different countries, to know exactly where are really the hotspots and what factors are explaining really the eclosion of these different, small outbreaks which are happening, and obviously to capacitate countries, to respond quite urgently with some kind of the engagement of the communities. The referral of some of the cases, the vaccination, as my colleague Fiona has mentioned. So really ramping up all of the different pillars of the response. I think this is very important, and to have this localized, really a well understanding of the dynamic of the pandemic. And for 2022, we are really thinking now, what are the projections? For sure, there are different scenarios. We can still continue seeing the same dynamic as at the moment, but the danger that we are foreseeing here is, the risk of reinfection, which can happen also, which can also create another dynamic here. And obviously, as we noticed in last year, when the Delta variant occurred, that created another dynamic. So, and as we know that the virus is circulating and mutation can occur, so all of these elements need to be taken into consideration while thinking ahead. But people have learned, people have need to continue to be really engaged, to be focused, to be able to take the actions as immediate as possible. And not only at the country levels, at the national levels, but really at the difference of national level. And WHO and the other partners are really doing all of the efforts currently for augmenting and increasing these readiness capacities. Thank you, and back to you, Mary.
Thank you, Dr. Balde. Dr. Benito, do you want to weigh in on this question?
Well, I think by there I said it all. For the timing, it should be okay.
Okay. So, Dr. Fiona, how is the COVID-19 vaccination drive faring on the continent? And then, Dr. Eva, if you can tell us, how is it faring among people with diabetes? Let's start, Dr. Fiona.
Thanks again, Mary. So The rollout on the continent is actually making steady progress right now, since we have gotten more doses than we had in the past. It has picked up well since the middle of the year, especially, but also in the last few months, starting September, October, because most doses started coming in at the end of August. However, the bottlenecks remain. When we see that the 6% is average for the continent, we have countries that are doing much more better than other countries. We have countries still at 0.1%, but we have countries that have reached 60-something% of fully vaccinated individuals. So we still have the hiccups here and there. Training, for example. These are different vaccine products that are in countries. Some need to be handled in under -70. Some need to be at 2 to 8 degrees. So the training of healthcare workers is still a hiccup, because with every new product that comes in, health workers need to be reoriented on that new product. But also the distribution of few doses of these vaccines. Normally, most countries distribute vaccines to their sub-national levels every quarter. But now with the COVID-19 vaccines, they come in with a short shelf life, meaning they must be distributed immediately because they need to be utilized immediately. But the other big issue that we face is the micro-planning, which means that the people at the national level, right to the most basic level at the service delivery point, must know how many people are we vaccinating, how many people got their first dose and are waiting for their second dose of a particular product because we want to give them a second dose of the same product, and where do we find these people? And if they have passed their estimated time between the two doses, that communication and also ensuring that the people come back for their second, that planning is very, very important. And finally, I'll mention community engagement. Because we are still seeing a bit of hesitance here and there in some of the countries, especially countries in Central Africa, that we still have higher hesitancy levels than the rest of Africa. But generally for now, the vaccine uptake is progressing steadily with more vaccine products and vaccine doses coming onto the continent.
Thank you very much, Dr. Fiona. We are happy that Africa is making progress with the vaccination. Dr. Eva, can you tell us how it is going among the diabetics?
Thank you, Dr. Mary, and thank you for the organizers for allowing me to stay in on this very, very important forum where we are communicating facts. And I think it's so good when we have journalists and being part and parcel of the drive to create awareness and spread the news. In Kenya, I must say that at some point, being in the NCD Alliance and also being a diabetologist, we saw a silver lining when COVID hit, because for once, the Minister of Health paid more attention to people with NCDs. Of course, that including the diabetics. So when we got the first vaccine, it was, of course, a few doses when it came in March. And the people who were prioritized were health workers, the healthcare professionals. And it was realized with the daily reports of the mortality and the number of patients in hospitals, and the minister and his team kept on announcing every day on the platform that the patients admitted in ICU, in HDU, patients who are dying, over 40% of them have comorbidities, including hypertension and diabetes. So within 1 month of rolling out the vaccine, the ministry changed its list of prioritizing the groups, and people with comorbidities, including diabetes, were put on top of the list together with the healthcare professionals. And that gave us a sigh of relief. So as NCD Alliance and also as a diabetes specialist, we went out on a drive, engaged the people with diabetes support groups to reach out to their members and give them this news and to advise them where the vaccination centers are. And with that, we have seen most of our patients who have diabetes have voluntarily gone and got the vaccine. So we still have now the people with comorbidities contributing to maybe number 3 of the prioritized list. That's the essential health workers, including teachers and, of course, medics. So I must say that this really has been, I would say it's a fair way of looking at the government and the policymakers changing their stand on the NCDs. So we are hoping this is going to continue, and at least I know, as we've heard about the rollout, we are pushing. We have several centers. We increase the centers where the vaccine is going to be administered. Trained Ministry of Health has trained people in the vaccine delivery. So I think I'm hopeful that if we can continue at this rate, we will be vaccinating. Maybe the target for the government is that by end of this year, we have reached hopefully 30% of our population. So over to you, Mary. Thank you very much.
Thank you very much, Dr. Eva. We are happy to know that at least we are not leaving the people that are diabetic behind with the COVID-19 vaccination. So thanks very much. And to you, Professor Mbaye, there is this question from the Senegalese press, and please feel free to answer in French. Can you talk to us about the situation of people living with diabetes in the context of COVID-19 in the center where you manage? Professor Mbaye?
Thank you, Mary. Très tôt, avec le début de cette pandémie, nous avons mis en place au niveau du centre Marc-Saint-Calais un système de téléconsultation pour justement protéger à la fois le personnel de santé, mais aussi les patients à qui nous avions recommandé de toute façon de maintenir la distanciation physique. Donc, les patients ont été invités à contacter des numéros verts mis à leur disposition avec des médecins qui étaient de garde tous les jours pour répondre à leurs questions, pour regarder les résultats d'analyse quand ils pouvaient nous les envoyer par photo et puis leur envoyer en retour, par exemple, les ordonnances ou des analyses supplémentaires à faire. Et ceci a très bien fonctionné grâce à la forte pénétration justement du téléphone mobile au Sénégal. Vous savez que le taux de pénétration du téléphone mobile au Sénégal est bien supérieur à la moyenne régionale de l'Afrique subsaharienne. Il semblerait qu'on est à 117%, avec plus de 80% de la population qui a un téléphone mobile et avec une bonne connexion Internet également comparée à la sous-région. Donc, ceci a rendu possible cette téléconsultation. Et en même temps, nous avons continué à assurer les soins pour les patients qui n'avaient pas accès à Internet ou à la téléphonie, et nous avions un système de garde permanent. Bien entendu, le nombre de consultations a beaucoup diminué pendant cette période. On est passé d'à peu près 8 000 en 2019 à 6 000 en 2020, donc une diminution de près d'un nombre de 2 000 cas de consultation. S'agissant maintenant des cas de COVID+, les patients atteints de COVID, c'est bien tard dans le développement de la pandémie, au cours de la 3e vague de cette dernière vague, que nous avons eu un centre de prise en charge des cas COVID au sein de notre structure. Avant, ils étaient pris en charge dans d'autres CTE en dehors de notre hôpital. Et comme vous le savez, les statistiques sont toujours difficiles à obtenir parce qu'il n'y a pas un retour immédiat, mais elles ont été collectées au niveau du ministère de la Santé, au niveau du centre d'opération des urgences sanitaires, et il sera possible de les avoir ultérieurement pour les analyser. Je vous remercie.
Thank you very much, Professor Mbaye. And then this question is coming to Dr. Fiona. The question is from Pauline from East Africa. In East Africa, what is the most significant hurdle as far as the vaccination drive is concerned? And have government introduced any vaccine mandate? What do the governments have to do to plan to accelerate the vaccination campaign? And to what extent is the limited access to vaccination affecting the reopening of the economy? So over to you, can start, and Dr. Benito or Dr. Bade for waiting.
Thanks again, Mary. So in East Africa, the most significant hurdles run across the same areas just like the rest of Africa. And up till recently, the biggest issue, as I mentioned, was vaccine supply. which we have now somehow overcome that hurdle, which is because steadily increasing in the past few months. Now we are focusing on addressing gaps and scaling up vaccine uptake. So in terms of operations and funding, countries now, we are getting more and more funds to support countries to increase their funding up, their vaccine uptake. Many multilateral banks have put funds out there to be accessed, but also governments have dedicated funds to increase their operations. As I mentioned before, the training of healthcare workers, the planning and ensuring that the micro-planning is on point. These people with comorbidities, Africa is not a continent that really looks out for people with comorbidities until they're sick and come to hospital, and somehow it is a coincidental finding. So we don't even know how many they are and where to get them. But for those that we know, to see that they are fully vaccinated. Of course, the monitoring also of adverse events and issues to deal with communication, like I mentioned before, are still on the radar. So what do governments have to do? There was a question on the mandates. So governments are sovereign entities. Governments, WHO has requested that for now, until we have enough vaccine to cover everybody, up to 40% of the population till the end of year and 70% till mid next year, we are saying that we should not put mandates on individuals that haven't been vaccinated, probably because they've not yet lain the priority groups or they have not been able to access the vaccine. But countries, again, are sovereign and can ask for anything they want at any particular point. But what are we asking governments to do to accelerate their campaigns? We have asked and are supporting member states to do what we call intra-action reviews, for them to assess where they are so far, what has worked well and what has not worked well, and what needs to be addressed. And as we identify their successes and challenges, then they're able to update what the plans we have. Each country has the national deployment plan. So from the intra-action review, they update their intra-action plan and are able to assess how much do they need to vaccinate a certain percentage of their population, and where will these funds come from, and we help them to access those funds. So the last question, Mary, sorry, I missed that.
Yeah, the last part is about how the limited access to vaccination is affecting the reopening of the economy.
All right, so we have seen some countries, so I still think this is East Africa. We have seen Kenya widely open up, which is very good, but a country like Uganda, which still remains most likely the only country that has had schools closed for about 2 years, still closed until the president put an ultimatum until a certain percentage of the population has been vaccinated. So we've gone ahead to help Uganda access vaccines enough to vaccinate all their teachers, all their the people working in higher level institutions, the lecturers and the support staff, and students above the age of 18, so that the country is able to open up the schooling and the economy for people to access, for children at least to go back to school, but of course also for the economy to fully reopen. We know that Rwanda is also a high absorber. Basically, actually in Africa, all the East African countries are being able to absorb vaccines as they come. They've been allocated a lot of doses. They are going to utilize those doses by the end of the year, increase the percentage of people who have been vaccinated, and economies to fully reopen just like Kenya has done. Over to you, Mary.
Thank you very much, Dr. Fiona. Dr. Benito, any addition from you?
It also, it should be okay.
Okay. Royal Uche, can you ask your question live? Are you ready?
Yes. Okay, so this is Royal Uche from SciDev. So one of the issues that Nigerians who live with diabetes are facing is the fact that they can no longer control most of them can no longer control their condition because of high cost of drugs and monitoring devices. And the group of people who bear that brunt are children. So I want to know what the Nigerian government and stakeholders, what can they do to tackle this issue?
Okay, thank you very much. I think I will start with Professor Dango. Can you reflect on what they can do? And then if Dr. Eva could also complement from the Kenya experience.
Sorry, Mary.
Yes.
Yes, I'm here. Please, can you come again on the question?
She's talking about accessibility to medications and what can the Nigerian government do? What is the advice to ensure that people have access to this medicine? So ability to pay, especially children.
Thank you very much, Mary, and for the question. I think for us, it's clear. WHO has defined some decades ago what we call the pillars of the health system. So if one country, one government would like to tackle issues around diabetes, including type 1 diabetes in children, they should consider each of the pillars of the health system, starting with governance, health governance, going through health information systems, service provision, etc., etc. All those 6 pillars of the health system should be considered, and for each of them, how to tailor that pillar to diabetes. For example, financing. In most countries, we are all crying we do not have enough funding to implement interventions and our plans in general. So it's important for governments to allocate domestic funding to tackle diabetes issues, but also to engage partners and also to do a lot of resource mobilization. The issue of the health workforce, which is one of the pillars of the health system. So health workforce should be well-trained, they should be skilled in terms of preventing and managing diabetes. So that's something very, very important. The supply chain. We all know that during the COVID pandemic, because of the lockdown, there was a shortfall and a completely, how do you say it? Insulin, which is a medication very important for diabetes management, was no longer available in countries. So the issue of supply chain should be taken into consideration. Service delivery also is something important. And in WHO, we have developed some tools, some guidance in terms of facilitating and improving access to diagnosis, treatment, particularly at primary healthcare level. There is one tool we call the WHO PEN, which is WHO package of essential NCDs interventions to be implemented at primary healthcare level. And in this package, we do have some protocols related to diabetes. We also developed another package for implementation at the intermediate level of the health system, what we call the PEN Plus. And there also, we do have packages to strengthen and improve service provision at country level. So these are the main recommendations we could give to countries when they decide to tackle diabetes. Over to you, Mary.
Thank you very much, Professor Dango. Briefly from you, Dr. Eva, how do you ensure access to people in Kenya?
Thank you, Mary. And I want to echo what Dr. Dango has just said about the strategies to improve the supply chain. I'll say in the last few weeks, Kenya and Uganda has published a forecast on a document that addresses a 5-year costed forecast for diabetes and hypertension, which truly will inform policymakers on how to allocate more funds, especially for essential medicine, insulin, and oral medications for diabetes, as well as diagnostics. And to address, in that same document, it also addresses prevention of diabetes. So I think this is very, very important. It's a plus for Kenya and Uganda. And I think this is going to go far to make sure that our patients receive the medicines. The other aspect is that we have, within the Ministry of Health, we have, in July, we launched our national strategy for NCDs for the next 5 years. And in those one of the pillars is looking into the supply chain and cost of medication and how our national hospital stroke health insurance fund will provide health budget packages that address the management and treatment for NCDs, including diabetes. And this is something that has been taken on very well by the ministry, because this is a Ministry of Health-driven strategy. And I think we are getting somewhere as far as is concerned. With the support of World Diabetes Foundation, we are rolling out a program for the next 3 years that's going to look into ways of getting management of type 1 diabetes institutionalized in the various health facilities by training the health workers, even up to community health workers who can track and follow up our diabetic patients, even at the homesteads. And this is going to, we've already started the program, and this is whereby stakeholders work together so that we have diabetes, the civil society, patients living with diabetes support groups, Ministry of Health, and now grant givers like WDF and other pharma come together, like Novo Nordisk, come together and make sure that we have especially what we call the Children Living with Diabetes initiative, and all these children, we have to register them, make sure they will never lack insulin. We'll provide them with glucometers. We'll provide them with periodic HbA1c and visits by a diabetes specialist. So I think we are making strides. It is quite late, but every step, long journey starts with a step. And I'm quite positive and hopeful that we are in the right direction. Over to you, Mary. Thank you.
Thank you very much, Dr. Eva. So now we are coming to the end of this first briefing. I'm going to give our panelists 1 minute each to conclude, and then 1.5 to Professor Mbaye, because I want you to just reflect a bit as well on how you are improving access to diabetes medication, especially for children in Senegal, and then your final words, then Mr. Greg, and then finally, Dr. Benito. So let me start with you, Professor Mbaye.
Thank you again, Mary. For diabetes medication, very early, the government has subsidized insulin. So insulin is available and is subsidized every year by our Ministry of Health, and is less expensive than in neighboring countries. And this allows more people to have access to the medication. And since 2018, Senegal is participating to the CDIC program, Changing Diabetes in Children, which is a program set by our Ministry of Health in partnership with Novo Nordisk that gives access to free insulin and equipment for monitoring, glucose monitoring, and also access to education and surveillance to all children involved in the program. And this has helped a lot to involve more children and to do a proper follow-up. So these are things I wanted to change with you. Maybe people, all countries should rely and maybe try to use the Patients Association to advocate in getting support from our governments. And this has worked very well in Senegal with our Patient Association, which is very strong and which helps a lot the health system to improve access to medication. For my final words, I would let me switch back to French. We are aware, on sait actuellement que le combat n'est pas fini. Il y a encore beaucoup de choses à faire, au Sénégal en particulier. Concernant le diabète, il sera important de mettre en place un programme national avec des stratégies, des objectifs, un financement. Ça, c'est primordial. Renforcer la surveillance épidémiologique du diabète et aussi des maladies non transmissibles de manière générale, parce que ça, c'est important pour la planification. On est conscient qu'il n'existe pas de solution simple. mais le fait juste de coordonner les différentes interventions, surtout celles qui ont prouvé leur efficacité, et aussi d'adopter cette approche multidisciplinaire et multisectorielle que Greg a mentionné dans son intervention, incluant les pouvoirs publics, les prestataires de soins, les associations de patients, comme je le disais, la société civile, l'industrie pharmaceutique et même l'industrie agroalimentaire, les professionnels de la communication, les journalistes. Ceci pourrait aider à améliorer la situation. Et s'agissant de la COVID nous a donné des leçons, nous a montré qu'il était temps que nous améliorions notre système de santé. Il faut certes relever le défi actuel de la vaccination, et sur ça, nous comptons beaucoup sur les journalistes qui doivent nous aider à accroître la sensibilisation, mais aussi et surtout à lutter contre la désinformation. Et il faut améliorer le système de santé de telle sorte à pouvoir garantir la continuité des soins s'agissant de maladies non transmissibles et de pouvoir lutter parallèlement aux affections aiguës, que ce soit la COVID ou toute autre affection qui pourrait survenir dans l'avenir. Je vous remercie encore.
Merci beaucoup, Professor Mbaye. And Mr. Greg, please, your final thoughts.
Thank you very much. Professor Maimouna has said it very well. I now try and see if I can add to this. Our message is that we can reduce the impact of COVID-19 if we start looking at diabetes and preventing diabetes. First important message. Diabetes is a silent pandemic, and we're talking a lot about pandemics at the moment. Diabetes is a pandemic, and it's time to raise this topic to the front of the conversations. We need to, as individuals, as communities, we need to make more noise about this issue. And we also need to communicate better among ourselves and with people outside of the sphere of the medical sphere. We need to reach out to people in a much more broad way. There are innovations, there are champions and heroes of diabetes in Africa, and we need to know more about them and share this information. We had questions about reducing the cost of medicine and healthcare in West Africa. Well, in East Africa, there are currently efforts to reduce the cost of medicine by working on the supply chain with bulk orders. We can share this information among ourselves. We also need to make it easier to import innovative devices into African countries. That's not always something that is straightforward. So there is a lot we can do, and we are calling on the media to emphasize the burden of diabetes and the importance of treating diabetes. Thanks again.
Thank you very much, Mr. Greg. And then to you, Dr. Benito.
Thank you, Mary. Let me start by expressing my sincere thanks to all the journalists and the panelists for taking their time out of their busy schedule to attend this press conference. I think three key messages. The first one, based on the exchanges we've been having, the pandemic is not yet over. We need to remain vigilant. The second one, while we are dealing with COVID-19 pandemic in the African region, we're still having other diseases like non-communicable diseases, including diabetes, that need to be addressed. So there's a need for all of us to really ensure that we can fight both COVID-19 and non-communicable diseases, including diabetes. To do that, there's a critical role of healthcare workers. We also need to ensure that we pay attention to what needs to be done to strengthen our health systems in our countries, because at the end of the day, this is the system that should be taken care of, not only COVID-19, but also non-communicable diseases, including diabetes. I would like to reiterate the availability of WHO to continue working with all partners, all member states, to ensure that we can fight both COVID-19 and diabetes and ensure that we can attain all our health goals in this region. So with that, I thank you very much. Back to you, Mary.
Yeah, thank you very much, Dr. Benito. And thanks to everyone. We have come to the end of the press briefing, but before we go, I would like to ask us a question and also challenge us. So when last did you check your blood sugar ahead of this diabetic week? And if you haven't checked your blood sugar in the last 1 to 3 months, my challenge to you will be, please, before the end of this weekend, check your blood sugar and pass the message out there. Thank you very much. A very big thanks to all our panelists, and thanks to our journalists and everyone that made this press briefing a success. Do have a nice day, and let's meet next week. Thank you.
Thank you.
Thank you, Mary. Thank you, Mary. Bye-bye. Thank you. It was
Bye-bye.
lovely.
Thank you.
Fantastic session. Thank you. Thank you, Greg.